Welcome back to the deep dive. Today we are really getting into the weeds on Chapter 16, Anti-Inflammatory, Anti-Arthritis, and Related Agents.
We are. And our mission today is to go way beyond, what's in the average medicine cabinet. We're looking at the powerful ways these drugs work with the body's own systems.
And it all starts with the inflammatory response itself. I mean, it's designed to be protective, right? It signals damage with swelling, with pain.
Exactly. It's a warning system. But the problem starts when that response becomes chronic or just excessive.
Right.
Then the very chemical mediators that are supposed to help us, things like prostaglandins, they start causing real tissue damage. And that's what all these drugs are designed to stop.
Okay, so let's unpack this. We're hitting the three big ones today. Salicylates, which are the oldest, then the NSAIDs, and finally the really targeted DMARDs.
A huge landscape.
It is. Let's start at the beginning with the original anti-inflammatory, salicylates. I'm thinking aspirin, mainly.
Yep, aspirin's the prototype.
Yeah.
And these are fascinating because they're historically from things like willow bark. They have this unique triple action.
Or triple threat.
Exactly. They're anti-inflammatory, they're analgesics, pain blocking, and they're also antipyretic, which means they block fever.
And the mechanism for all three of those actions really comes down to prostaglandins, doesn't it?
It does, for the most part. Their main job is to inhibit prostaglandin synthesis. That's what handles the inflammation and the pain.
And the fever.
For the fever blocking effect, they target prostaglandin mediators, but specifically in the thermoregulatory center of the hypothalamus. It's like they go in and just, reset the body's thermostat.
This is where it gets really interesting for me, how this connects to heart health. We all know about low-dose aspirin for preventing heart attacks, but it's a real balancing act.
It's a very delicate balance.
Yeah.
Aspirin has this dual effect on platelets. At low doses, the doses you use for cardioprotection, it strongly inhibits something called thromboxane A2. That's the one you want to block. It promotes clots.
The bad actor.
The bad actor.
Yeah.
But if the dose gets too high, it starts to inhibit prostacyclin, which is actually the good actor. Prostacyclin prevents clotting. So you can see how the dose is absolutely critical.
And that's why getting the dose wrong is so dangerous. It pushes you into the territory of, what's it called, salicylism?
Salicylism, exactly. That's the toxicity syndrome from high levels. And for anyone monitoring a patient on these drugs, the classic sign you have to watch for is tinnitus.
The ringing in the ears.
That persistent ringing, usually followed by dizziness, maybe some hearing loss, even confusion. It's a huge red flag.
And speaking of red flags, there is a massive life-threatening one when it comes to kids.
This is non-negotiable. You should not give salicylates to children or teens who are getting over a viral infection, specifically things like the flu or chickenpox.
Because of Ray's syndrome.
Because of the risk of Ray's syndrome, which can be devastating, even fatal. It's a critical piece of patient education.
And what about just, simple administration? Any key safety points for the nurse?
Two big ones. First, these can be really hard on the stomach, so always administer with food. And second, aspirin can degrade. If you've opened a bottle and it has a sharp vinegar smell,
Drought.
discard it immediately. That means it's broken down into acetic acid. It's no longer safe or effective.
Okay, let's shift gears now to the class everyone knows. The NSAIDs, or nonsteroidal anti-inflammatory drugs, ibuprofen, naproxen, all of those.
Right. This is a huge group. And they're popular because they give you really strong anti-inflammatory and pain-relieving effects.
And their secret weapon, so to speak, is how they target the cyclooxygenase enzymes.
Yes, and this brings us to the really famous KOX1 versus KOX2 divide. If you can understand this one concept, you can understand almost all the risks associated with NSAIDs.
I find this part fascinating, just how the body uses these two enzymes differently.
It's so elegant. So traditional NSAIDs, like ibuprofen, they block both enzymes. Now, KOX2 is the one that's active at the site of an injury.
The inflammation enzyme.
Pretty much. Blocking that gives you the anti-inflammatory effect you're looking for. The problem is KOX1.
And KOX1 is the good guy, right? The one that's just always running in the background, doing important jobs.
Precisely. It's the housekeeping enzyme. It's in all your tissues, protecting your stomach lining, helping your blood clot properly, maintaining kidney function. It's vital.
So when a drug like ibuprofen blocks both, you get the pain relief from blocking KOX2, but all the collateral damage, the GI bleeds, the kidney issues, that's from blocking KOX1.
That is the fundamental trade-off. And that's why the KOX2 inhibitors like celecoxib were developed. The idea was to only target the injury enzyme and spare the housekeeping one.
A great idea in theory. But it didn't quite work out that way, did it? This leads us to the huge controversy in the black box warnings.
It does. I mean, we saw drugs like Vioxx and Bextra pulled from the market
Yeah.
because of a huge increase in cardiovascular events, like heart attacks and strokes.
And why was that? What was happening?
Well, it seems that by only blocking KOX2, they threw off a delicate balance. It disrupted some protective responses in the blood vessels, which actually increased the risk of forming clots,
Huge unintended consequence.
a massive one. And because of that, all prescription NSAIDs now carry a black box warning about CV risk. And they are absolutely contraindicated right after heart bypass surgery.
Before we move to the next class, we have to talk about the one that's sort of an outlier. Acetaminophen.
Ah, yes.
Mm-hmm.
Tylenol. It's in a class all by itself.
So it's great for pain, great for fever. But the key difference is...
It has absolutely no anti-inflammatory effects. Zero. It works directly on the hypothalamus to bring down a fever, but it doesn't touch the inflammation pathway.
And its safety profile is all about one organ.
The liver. The risk is severe hepatotoxicity, and it's almost always from an overdose. The most dangerous scenario is accidental. Someone takes a pain reliever, then a cold medicine, then a flu remedy, and they don't realize that all three contain acetaminophen. The doses stack up incredibly fast.
It's an easy trap to fall into. Is there an antidote for that?
There is. If you catch it in time, you can administer acetylcysteine to counteract the liver toxin.
Okay, let's move on to the heavy hitters, the most powerful specialized class,
Right.
the Antiarthritis Agents, or DMARDs.
Right. These are for chronic, really debilitating joint inflammation like what you see in rheumatoid arthritis.
And historically, the treatment was gold.
Believe it or not, yes. Gold salts. It's called Chrysotherapy. The gold gets taken up by macrophages, and it actually inhibits phagocytosis, which slows down the tissue destruction. It's pretty wild.
It sounds kind of ancient, and I'm guessing the side effect profile is pretty rough.
It's very toxic, which is why it's a last resort now. Gold gets deposited all over the body. It can cause severe skin issues, mouth sores, and really dangerous bone marrow depression.
So what's the modern approach? The real game changers seem to be the tumor necrosis factor blockers, the TNF blockers.
Oh, absolutely. Drugs like etanercept or adalimumab, what's so amazing here is that we're targeting a single specific cytokine TNF.
And TNF is like the master switch for inflammation in this case.
It's one of the main engines driving it. So if you can deactivate PNF, you can slow down that whole inflammatory cascade and prevent the joint damage before it happens. It's a huge leap forward.
But that benefit comes with, an even more serious black box warning than the NSAIDs.
It has to. You are intentionally shutting down a key part of the immune system.
Yeah.
So the warnings are very, very serious. Risk of fatal infections, reactivation of things like latent TD or hepatitis B, and an increased risk of lymphomas and other cancers.
Wow. So patients need some serious screening before they even start these.
Extensive screening.
Yeah.
For TB, hepatitis B, HIV, you have to know their immune status is clear before you suppress it.
Okay, so that brings us to our final segment, really pulling it all together. Synthesis and nursing responsibilities. Because so many of these are either OTC or incredibly high risk, the nurse's role is just paramount.
It really is. Assessment is constant. You're screening for contraindications across every single class. Bleeding risk for NSAIDs, kidney and liver problems for almost all of them, and then active infection or cancer for the DMARDs.
What about lab work?
You're monitoring CBCs, liver and renal function tests, and doing stool guaiac checks for that hidden GI bleeding.
And let's circle back to that medicine cabinet danger. What's the #1 teaching point about combining OTC products?
You have to teach patients to become label detectives. Read every single label on every pain, cold, or flu product. Teach them to look for a salicylate or acetaminophen to avoid that accidental stacking of doses.
The source material also pointed out a really important cultural consideration.
Yes, and this is clinically significant. Studies have shown that African Americans can have a decreased sensitivity to the pain-relieving effects of many of these drugs.
So they might need a higher dose for relief.
Potentially. But here's the catch. At the same time, they have an increased risk of the GI side effects. So it requires this really careful balancing act, titrating the dose for pain relief while being extra vigilant about monitoring for any GI distress or bleeding.
And finally, for patients starting one of the injectable DMARDs, what's the core safety teaching they have to leave with?
It's meticulous. You have to teach them proper sterile technique for subcutaneous injections, how to rotate their sites, safe needle disposal, all of that.
And the bigger picture stuff.
The bigger picture, you have to stress the need for routine cancer screenings And they must understand that any sign of infection, even just a little cold, needs to be reported immediately because their immune system just can't fight it off like it used to.
So to wrap it all up, salicylates block prostaglandins but carry that Rey syndrome risk. NSAIDs block both COX enzymes, bringing major GI and heart risks. Acetaminophen is just for pain and fever, but with a fatal liver risk. And then DMARDs target the immune system itself, which means a constant threat of infection and cancer.
That's a perfect summary. And if we connect this to the bigger picture, it brings up a really tough question for any provider.
Which is?
When you're managing chronic pain, how do you balance giving a patient the symptomatic relief they desperately need right now against the very real, long-term, and potentially fatal organ damage that comes with almost every single one of these drugs?
It's a risk-benefit tightrope walk every single time. And knowing these mechanisms, these warnings, that's the only way to walk it safely. Use this knowledge to sharpen those critical distinctions in your own practice. Thank you for diving deep with us today.